Did you see it now?
No, we're still not able to see it.
What happened here?
There we go.
Now
There we
you, okay. So let me put it on slide mode. Okay, so we're back in business here. All right. So any CNS disorder, anything that disrupts brain structure and function can cause psychotic symptoms. Various drugs of abuse, not alcohol and various other drugs, especially cannabis, it's terrible. Iatrogenic, a lot of prescription medications that you prescribe in your practice as an internist can actually cause psychosis in some patients, not everybody. Various toxins, heavy metal poisoning and others. Autoimmune diseases are notoriously associated with psychotic symptoms. Keep your eye on those. Various chromosomal abnormalities also can be associated with psychosis. Various infections, especially cerebritis and encephalitis, can actually trigger a number of psychiatric symptoms, especially psychosis. Severe nutritional deficiencies can also do, I'm talking severe here, can result in psychotic symptoms. Various endocrine disorders have been well established to generate psychotic symptoms. And metabolic disorders, again, you see a lot of those in your practice, can also trigger psychotic symptoms. And so all of these are not schizophrenia, but psychotic symptoms, and the treatment is different than schizophrenia. Now let's talk about the cause of schizophrenia itself. We divide them into genetic and non-genetic. And frankly, the latest number in the literature now is that 79% of all schizophrenias are genetic. 79%. I'm going to show you what are the genetic pathways. But first, remember, of the 22,000 protein coding genes in our chromosomes, in our genome, 50%, about 10,000 genes are involved in brain development. So this incredible organ, the brain, is more complicated than any other organ in the body. There are 200 tissues in the human body. Brain tissue is one of 200, and it gets 50% of all the genes. So now you understand why psychiatry is so sublime. Now let's look at the GWAS, genetic gene-wide association studies. Several studies have been done showing that there are many risk genes in patients with schizophrenia that we don't see in the general population. Look at the bottom of the slide. You see the chromosome number from 1 to 22, and then the X. And whenever you see a tall bar, we call it Manhattan plot because it looks like the skyscrapers in New York. But actually, anything over the red line is extremely significant, like P less than 14 zeros and 1. Okay, that's extremely significant. And the taller the bar, the more significant. Look at the chromosome 6. It has the highest significant difference. You know what that is? That's the histocompatibility complex. That tells us there's something immunologically wrong in schizophrenia, disruption of the immune system. But there are a lot of other loci, 108 genomic lesion, and total is about, here's a summary of the genetic pathways. These risk genes I just showed you, so far we've identified 413 genes, risk genes, that are found in schizophrenia patients, 50,000 versus 50,000 controls. That tells you there are several hundred types of schizophrenia, biological types. They look the same. The clinical phenotype may be similar, but they are really different biologically. And then you have copy number variations. We're finding a lot of those genes for brain development either with a deletion or a duplication. So they have one allele or two or three alleles. So they make too much protein or too little protein that disrupts brain development. Schizophrenia is a disorder of brain neurodevelopment in fetal life, and those genes are responsible for that. Then you have mutations. A lot of mutations occur in nature, bad mutations, good mutations that can lead to evolution. But because 50% of all the genes are involved in brain development, 50% of all the bad mutations actually affect the brain. So you get schizophrenia, bipolar disorder, autism, mental retardation, but also epilepsies and Parkinson's disease and MS and so on and so forth. And then you have the epigenetics, which is modifying existing normal genes into abnormal genes, which brings me to the environmental causes. Now you can see from the genetic pathways how many hundreds of schizophrenias we have, okay, plural. Look at the childhood trauma. Numerous studies published have shown that children who are physically, verbally, sexually abused, or severely neglected in the first 5-6 years of life will have a high risk of schizophrenia or severe depression or suicide. This is the childhood trauma modifies the kid's genes, suppressing some genes, overexpressing other genes, and that leads to adult psychopathology. But focus on the pregnancy and delivery complications. This is where many environmental causes for schizophrenia develop. In children who are, who did not inherit any genetic abnormality. Examples of published literature here is severe infections during pregnancy, viral, bacterial, fungal, you name it, can increase the risk of schizophrenia in this fetus when 20 years later, when it's an adult. Gestational diabetes. If a woman who's pregnant develops diabetes during pregnancy, 800% higher risk of schizophrenia in adulthood. Severe vitamin D deficiency, 400% increase of risk of schizophrenia, and because vitamin D is so critical for early brain development. And then you have substance use, you have hypothyroidism, even smoking cigarettes during pregnancy. Nicotine can disrupt brain development. And of course, the delivery complications. Anything that causes hypoxia is really traumatic to the brain and can disrupt brain development during delivery. And we see that a lot, actually, in patients by history. Urbanicity. This is an interesting study. Several studies have shown that people who are born and raised in a large metropolitan area of at least 1 million or more have 500% more risk of schizophrenia than people born and raised in a rural area. Okay, we don't know the exact reason. We think it has to do with stress in busy cities. Stress, infection is more likely, crowded cities, or pollution, etc. All of these affect the brain of the baby during pregnancy. Migration is another factor. People who migrate from one country to another have a higher risk of psychosis in the new country. Paternal age. It's been shown in several studies that if a male decides to have a baby after age 45, the risk of schizophrenia, autism, and bipolar disorder triples, 300% higher. Not all the kids are abnormal, but the risk is 3 times higher. Again, this may be due to, we believe, to DNA fragmentation and aging sperm. So as you can see, there's a lot of schizophrenias and a myriad of genetic and environmental factors. So it's a syndrome. It's not a disease. It's multiple, hundreds of diseases. Now let's switch gears and talk about what happens when patients become psychotic and come to our hospital with the first episode psychosis. There's a lot of brain tissue damage. This is an example of a patient, the first psychotic episode. This is one MRI at the bottom, second in the middle, and a third on top. You can see that this is the coronal view of the ventricles show significant enlargement of the, let me see if I can get that laser pointer going. So you can see the ventricles are enlarged already. In first episode, there's tissue loss. 3 episodes later, the ventricles have tripled in size, more tissue loss. The more cortical tissue you lose, the more dilatation of the ventricular system. And after 8 psychotic episodes, unfortunately, we let so many patients relapse unnecessarily. The brain of this patient looks like early Alzheimer's. So I actually tell my patients that, you better take your medication or you're going to have a severe brain tissue loss. Here's an example of many studies showing with the first episode alone, 1% of brain volume is lost. Now, the brain is 1,200 cc's on average. So 1% is 12 cc's of brain tissue is lost in the first episode alone. And each cc has hundreds of millions of cells and billions of synapses. You can see the brunt of it comes out of the cerebral gray matter and the ventricles are large. And every episode, roughly 12 cc's are lost. So you can do the math. If patients are allowed to keep relapsing and we don't do anything about it, they are going to lose 30, 40, 50, 60 cc's of brain tissue. It's impossible to remain normal and not be disabled when you lose that much brain tissue. Now, what's the reason that psychosis causes brain tissue damage? This, again, something we found in the last 15 years. Oh, by the way, we did not know until about 20 years ago, around the turn of the millennium, that psychotic symptoms destroy brain tissue. The psychiatrists were totally ignorant in the 60s, 70s, 80s, 90s. They had no idea that psychotic episodes are neurotoxic, neurodegenerative. So they didn't take it seriously. They didn't care if the patient relapsed, if they didn't adhere to medication. and they didn't realize how serious it is. Now we do, there's no excuse anymore. So around the same time, this last 15, 20 years, we discovered two processes that destroy tissue during psychosis. And they're due to the activation of the microglia. The microglia, about 10% of your brain cells are microglia. And they usually are excellent support system for the neuron. And they handle the immune system in the brain, by the way. But when they get activated by psychosis, we call it microglia activation, they start releasing massive amounts of inflammatory biomarkers, cytokines, and also free radicals, both of which destroy brain tissue. And that is why the patients lose brain volume. Post-mortem studies also show the ravages of psychosis. Dendrites lose more than 50%, up to 50% of their length, which is devastating because dendrites is where all the synapses are. They connect all the brain regions together for to integrate the brain into one functional organ. The dendritic spines go down in size and number. Let me show you the dendritic spines. You see here upstairs, this is a normal person at post-mortem. All the dendrites in a normal person's brain have extensive amount of spines. These little blips, they look like grapes on all the dendrites. These are what we call spines. What are the spines? These are immediate memories that you form whenever you experience anything. 24/7 throughout your life, you make spines all the time. You just made several 100 million spines just listening to me in your visual area, auditory area, in the limbic system, because I'm making you feel and think. So this is what normal people do, continuous encodement of memories biologically. Look at the patient with schizophrenia in the middle. Psychosis wipes out the spine, and they cannot form any more spines. This is why they cannot learn new things. They cannot remember things. Your autobiography, your life autobiography is encoded in the spines, and the patients don't even know anything about their past. And so this is extremely devastating. Also, the neurite extension, the richness of the neuropil, like a tree in summer becomes like a tree in winter. You lose all the branching with psychosis, and then the glial cells die. As you know, microglia, astroglia support the neuron. Every neuron has about 15 to 20 glial cells that do all the work for it. They bring food in, they create neurotransmitters, they make synapses, and they defend it against infections and so on. So when psychosis kills half the glial cells, the neuron becomes a helpless unit, a helpless cell. It's like a CEO who loses all the vice presidents and program directors and the staff. You cannot do anything with a company when you don't have the staff around you. In addition, you have loss of neurotropic factors. Whenever patients get psychotic, they lose 50% of their NGF and BDNF, which are critical to keeping the brain steady in its volume and its function. So why do patients keep getting relapses in schizophrenia? Number one cause is non-adherence. And there are a lot of causes for that. It's not their fault. The illness itself makes the patient unable to take the medication without interruption every day. Just like our diabetic patients and hypertensive patients must take their medication every day. You can't skip days, but patients with schizophrenia skip numerous days, even weeks at a time. And the reasons are many. The first, the lack of insight. We call it anosognosia, as a neurological deficit. They refuse to believe they're sick. They don't believe they need the hospital. They don't want to take any medication. We have to force them into the hospital fortunately, we have state laws that allows us to commit them against their will so we can treat them and save them from this devastating brain disorder. They have also serious cognitive impairment. They forget everything. They have like 2 standard deviation worse memory than normal people. So they forget to take their pills. They have negative symptoms, which include apathy, lack of motivation, inability to initiate an action. That is also very disruptive to adherence. They interpret side effects as evidence that they're being poisoned because of the paranoia they have. So they ditch the medication. And then a lot of them, 70% of our patients with schizophrenia are abusing alcohol or drugs. And you know very well, if somebody is drunk or stoned, they are not going to take their prescription medication. So add them all together, you realize how our patients destroy themselves. They literally destroy themselves without realizing it. And psychiatrists are letting them do that. Because instead of intervening in a very aggressive fashion, like oncologists use chemotherapy immediately when they see cancer in their patients, not delay it until they are stage 4. That's too late. So Let's look at the logic of using long-acting injectables, which fortunately we have. Forget the pills; they don't need the pills. We can give them an injection once a month, and even once every 3 months now. And very recently, 6 weeks ago, the FDA approved a formulation once every 6 months. So there's no reason to entrust the patient with taking medication that if they don't take are going to doom them to total disability. So Dr. Emsley in South Africa was the first researcher to use long-acting injectables in fresh first episode patients, which no psychiatrists do. Still in the United States, 99.9% of psychiatrists discharge their patient on pills. We start with pills in the hospital. Absolutely makes sense to make sure they tolerate it, that they're not allergic to it, and that it works. But once they discharge, they get discharged. I believe we should put the patient on long-acting immediately, because it's a guarantee that most of them are going to relapse. So Dr. Emsley was the first one to show the benefit of using long-acting. He used risperidone back in 2008. He actually started it in 2006, published the paper in 2008. 2/3 of the patients complete remission for the full 2 years, and they did not get any more relapses. And they basically restored their function, their insight. They went to school, they went back to work. They had an excellent outcome. And then when he discharged them back to the referring psychiatrist, they were all put on orals, and guess what happened? 97% of them relapsed within a few weeks. And it's tragic, because when these psychiatrists realized what happened, they put them back on long-acting, and 16% of them no longer responded. Immediate treatment resistance develops whenever the patient got a second episode. This is well known because of what I just told you. The toxicity of psychosis disrupts neuron, basically disrupts the connectivity. The receptors are no longer the same. The brain changes with every psychotic episode, so no longer respond. 1/7 of the patient no longer responds. Here's another study from UCLA. Again, striking finding. They took 100 patients roughly with first episode. They treated them with second generation antipsychotic in the hospital. Discharged them half on oral, half on injectable. The same antipsychotic, half oral, half injectable. Followed them up for a whole year. Guess what they found at the end of the year? 650% higher relapse rate in the oral group compared to the injectable group. It's unbelievable what a difference it can make to give the patient the injectable of the same antipsychotic. It's not magic, it's common sense, delivering the medication to patients who are unable to take the oral pills in a very consistent, uninterrupted fashion. So this is what, a figure I created for one of my books. You can see this is typically what happens with patients with schizophrenia. A year before the onset of first episode, they go through the prodrome, where they start changing, becoming more withdrawn, more suspicious, have illusions. Their grades in school go down the tube, and they develop ADHD or OCD or depression symptoms, and then they show up at the door of the hospital, psychotic, and they lose a lot of function. But look at the V-shaped recovery. This is the only time in the life of a patient where you have immediate response. First episode, the brain is very responsive with low doses, and they go back almost to their baseline, and we beg them to stay on the medication. They don't. They relapse again, now more severe dysfunction, no more V-shaped recovery, delayed response, slower improvement, response is not as gratifying. And again, the same thing happens. We tell them to stay on your drug because it takes longer to reach back to their baseline, but they don't. They get a third episode, and so on and so forth, and the nth degree, and much more treatment resistance develops, and eventually they all become chronic schizophrenic, residual symptoms. And underneath, you see the brain is losing tissue with every episode, like I said earlier. This is the model that I propose, and I encourage all my residents to use it, and they do. Whenever we have a first episode patient, we treat them in the hospital with the oral, they bounce back nicely, most of them, and then we give them the injectable, and they maintain their baseline instead of letting them relapse again and again and again. And maybe after 10 years, like many psychiatrists do now in this country, they wait for the patient to have multiple episodes before they say, okay, I'm going to give you a shot. They make it sound like it's punitive. It's actually life-saving if you use it initially, as I recommend. Because look at the 7 tragic consequences of psychotic relapses. Brain tissue loss, 12 cc every relapse. Treatment resistance, you need higher and higher and higher doses with every episode. The patients get arrested and incarcerated. Most of our patients now go to prison There's no more state hospitals to admit them and treat them in a medical setting. It's tragic what happens. These patients become criminalized because they become psychotic and they get arrested on the street. They have a very high suicide rate. A recent article looked at a large number of patients, and it is almost unbelievable. It's 170 times, which is 17,000% higher risk of suicide in young patients after the first or second episode, early in the illness, compared to the same age group in the general population. So it's the worst outcome in medicine. Patients will kill themselves. And another study was recently published. Look, they took blood from the corpses of patients who committed suicide to measure how much antipsychotic was in their blood. And guess what they found? Zero. Most of them had zero antipsychotic in their blood, showing you that the lack of treatment leads to suicide. Disability, of course, vocational and social, they become basket cases. Everybody thinks schizophrenia is a hopeless illness because, frankly, most of them are, because of the practice pattern of 99.9% of psychiatrists in this country. They keep giving them pills that they don't take, so no wonder they suffer all of these tragic consequences, and they become homeless, and family suffers enormously if you ever talk to the families. So preventing the second episode is really a very important key ingredient in managing patients with schizophrenia. And that's why I wrote an article called, "For First Episode Psychosis, Psychiatrists Must Behave Like Cardiologists." It's exactly the same principle. Patients comes in with the first MI, the part of the myocardium has been killed forever, infarction, and every cardiologist knows that they should do everything in their power to never ever let them have even a second myocardial infarction. So they do multiple steps. They change the patient's life. You change your diet now to stop the high calorie, high fat, go to an orange diet, stop smoking immediately, risk factor, start rehabilitating, slow exercise, because most of them are conspirators. And then they give them multiple medications and hypoglycemic agents to reduce the glucose, antihypertensive to reduce the blood pressure, statins to reduce the lipids, all of those risk factors, in a concerted effort to protect them from the second episode. Psychiatrists should do no less. And the easiest thing to do is to switch them to long-acting injectables right after discharge from the first admission, switch from oral to injectable, and then see them every month and give them the usual psychotherapy, social skill training, vocational rehabilitation, cognitive remediation. We have a lot of psychosocial things we can do. But the key ingredient, the foundation of managing schizophrenia should be a long-acting injectable. Now, another thing that has emerged also in the last 15, 20 years is which antipsychotic should be used. For God's sakes, don't ever use the older drugs like Haldol. Okay, it works very well. I used it in the past before the second generation started coming in the mid-90s. The efficacy is unquestionable, but it turned out that they kill brain cells. Well, first let me show you that the atypicals actually stimulate the neurogenesis. They create new brain cells. Haldol and the other drugs actually do the opposite. They kill brain cells. This is an example of an animal study where you give the patient. This is actually without giving any drugs. You see the neurogenesis, newly born, basically progenitor cells, we call them, neurons and glia. They eventually differentiated to neuron and glia. They are formed and they migrate. We tag them with BRDU so we can see them. The brain is continuously forming new brain cells in the hippocampus and subventricular zone. And the second generation turbocharged this. But the first generation actually suppress it, and psychosis puts it complete stop. There's no more neurogenesis when the patient is psychotic. 31 published studies have shown now in neuroscience journals that there is neurotoxic effects of haloperidol and the other drugs. So I wrote a review article about this to bring it to the attention of clinicians, because most psychiatrists don't read neuroscience journals, unfortunately. So I summarized the findings in this table. Look at 15 bullets. Each bullet is a mechanism, cellular molecular mechanism of cell death. So haloperidol and the first generation drugs, chlorpromazine, loxapine, selazine, prolixin, all of these drugs can kill brain cells. And so that is why the patient continues to lose brain tissue if you maintain them on the first generation. But the opposite happens with the second generation. This is another study, completely different study, showing mortality. 180-day mortality with antipsychotic versus no antipsychotic. The highest risk is with haloperidol, okay? Which is clearly a very bad drug. What's the reason that the first generation is toxic, the second is not? It turns out to be the receptor profile. All the second generation drugs were modeled after clozapine. Okay, and the clozapine doesn't cause any extrapyramidal side effect. So psychiatric researchers said, well, how does what's the receptor profile of clozapine? Turned out it blocks the serotonin 2A far more than blocking D2. And when you do that in animal studies, it makes a big difference in releasing neurotropic factors. Too much dopamine blockade decreases BDNF. And if you block serotonin 2A 500% to 1,000% more, then you do the opposite. So there you see the antipsychotics here. Clozapine was the model for the atypicals. Far more green than yellow. Green is serotonin 2A binding versus D2 binding. So look at Haldol. It's the opposite. A heck of a lot of dopamine blockade, very little serotonin 2A. So all the second generation risperidone, Geodon, Sertindol, we don't have it here in Europe, although I did the clinical trials with it, but it causes QTC prolongation, so the FDA didn't approve it. But olanzapine and quetiapine, Seroquel, all of them have more green than yellow, which means they are atypical. And that means they actually induce neurogenesis and increase neurotropic factors. So I wrote another review article, how the neuroprotective effect, 24 different neuroprotective effects of the second generation drugs. These are examples. 12 out of the 24 in one slide. Enhancing neurogenesis, increasing neurotropic factor, reversing gene expression that PCP causes. PCP, by the way, is the worst drug that a human being can take because it can make you schizophrenic overnight with all the symptoms of schizophrenia. How does it work? An NMDA antagonist, the glutamate receptor antagonist. The atypicals even ameliorate ischemia from a stroke. They do this in animal studies. Stroke, causes a lot of ischemia. If you pre-treat the rat with a second generation drug and then ligate the carotid, the ischemia is far milder. But if you pre-treat the rat with Haldol and then ligate the carotid, the damage is just as bad as ever. And see, remember the dendritic spines I mentioned earlier with psychosis? If you give patients second generation drugs, they actually prevent the dendritic spines from being wiped out, which is very important, of course, for patients' cognition. And they also prevent the damage of oligodendrocytes, make the myelin in the brain. Myelin is extremely important because 60% of the brain is white matter, myelinated fibers, 40% is gray matter. And the white matter connects all the cells and regions of the brain. During psychosis, the free radicals and the cytokines, destructive inflammatory biomarkers, destroy both gray and white matter. So basically, you have to regenerate the white matter in order for the brain to become functional. And the atypicals do that. The older drugs do not. They even have anti-inflammatory effects and so on. So all in all, the benefit, it's a big benefit to give the second generation. I keep telling my fellow psychiatrists, for God's sake, stop using the first generation, because some of them still do. Now, here's another meta-analysis, 18 studies of patients where MRI scan was done progressively over like 10 years. Half of them were taking first generation, the other half were taking second generation. What did they find? They found that there's actually continuous loss of brain tissue with the first generation, FGA is first generation antipsychotic, whereas the second generation actually either keeps the brain the same or increases part of the hippocampus and the prefrontal cortex. This is the paper that I'm referring to. The effect of antipsychotic treatment, does class matter? Yes, it does. A huge difference according to the meta-analysis. This was published in Biological Psychiatry, one of the best journals we have in psychiatry. And then a very recent study added more reasons to use long-acting second-generation drugs, not only for relapse prevention, which is why I like to use them in the first place, but it turned out, and they are neuroprotective because they're second generation, okay? These are two benefits: relapse prevention, guaranteed adherence, and regeneration of the brain. This recent paper came out from Sweden. Here's the paper. This is a paper that came out of Sweden. It's an academic study. All the patients in Sweden, single payer, were followed up for 7 years. They kept them on the same medication to see, is there a difference in mortality in patients receiving various antipsychotics? Nobody has ever looked at that. We know mortality is very high in schizophrenia. They die prematurely 20, 25 years earlier than necessary. This study looked at the relationship between drugs, the antipsychotic, and mortality. And what did they find? Long-acting paliperidone, which is called Invega Sustenna here in the United States. I'm sure that Johnson & Johnson were thrilled to see this paper come out. They had the lowest mortality than any other antipsychotic over a 7-year period in about 30,000 patients. And here's the figure from the paper. Here's LAI, long-acting injectable paliperidone, 0.11. It's the lowest compared to all the other antipsychotic. And look at Prolixin. You know, some of your patients may be taking Prolixin injectable. It has 8 times higher mortality than Sustenna. This shows you that these are neuroprotective and the others are not. So mortality becomes a factor here. So that's why I wrote an article about the triple advantages of injectable second generation antipsychotics, relapse prevention, neuroprotection, and lower mortality. Okay. So to summarize then, with 100% adherence, most patients with schizophrenia not only stop relapsing, but they can actually achieve remission and gradually go back to their baseline, whatever their baseline is. And this is the key method to do it. Start long-acting injectable very early, just like cardiologists start preventing the second episode immediately after the first myocardial infarction occurs, and not wait for the patient to become totally disabled, or in the case of cardiology, waiting until the patient dies or have renal, you develop heart failure before you protect them. No, you do it early. An ounce of prevention worth a pound of cure. So thank you very much for your attention. I know I talked very fast to cover the material and leave some time for questions. I hope I do get some of your questions.
Thank you very much, Dr. Nasrallah. That was excellent, and you certainly kept the intention of a Department of Medicine focused on a psychiatric condition. So you made it very, very easy for even us to understand. So thank you. We have some questions coming in. So again, I'm gonna ask people, if you have questions, you can put them in the chat, send them to me, and I'm happy to read them. We have a question. So if activated microglia and neuroinflammation are contributing to schizophrenia, are there anti-inflammatory drugs that improve schizophrenia? And if not, why not?
What a good question that is. I didn't have time to show you some slides. Yes, there have been numerous studies where adjunctive anti-inflammatories were added to the antipsychotic to mitigate the inflammation during the acute episode. And this includes NSAIDs, aspirin, minocycline, and omega-3 fatty acid, which is my favorite. I use omega-3 as an anti-inflammatory agent as adjunctive therapy for all my patients because it does actually protect the patient from excessive inflammation, especially during the acute episode. And so yes, to answer your question, yes, but not solo. You do not use the anti-inflammatory alone. You have to use it as adjunctive therapy to a dopamine receptor, D2 receptor antagonist. Now, another angle to this question is the prodrome. The prodrome is a huge area of research now, which is recognizing the earliest symptoms of impending psychosis a year before the onset. And it started like about the year 2000. Now that we have many centers in the US and Europe and Australia doing this. And one of the major goals during the prodrome is, can we nip it in the bud? Can we prevent the patient from converting to psychosis by intervening during the prodrome when they start changing? Well, several antipsychotics were given, small doses, second generation, to those patients, and it didn't make any difference. Compared to placebo, the conversion rate was the same. So giving antipsychotic in the prodrome does not prevent this conversion to psychosis. Well, guess what worked? Based on our knowledge that there's inflammation going on in psychosis, the hypothesis was, could there be like the beginning of the inflammation in the prodrome? And sure enough, biomarkers during the prodrome, CSF and the serum show there's a huge elevation of cytokines, TNF alpha, interferon gamma, CRP, all of these inflammatory biomarkers. So a clinical trial was done, giving half the patients with the prodrome, half the patients got omega-3, and half the patients got placebo. They followed them up for a year, and there was a huge 400% lower conversion to psychosis in the omega-3 group compared to the placebo group. This was published, got a huge amount of publicity, attention, that perhaps throwing a bucket of cold water on a little fire starting during the prodrome can protect the patient from a huge conflagration, which is the psychosis. So omega-3 as an anti-inflammatory could actually be used. And I actually suggested to families with a family history of psychosis, I tell them, give your teenage kids some omega-3, protect them early on. Like, it is actually not harmful at all. I take omega-3, everybody does. It's a good supplement, but in their case, we give it as an anti-inflammatory. not as a supplement. And it does, we believe it's going to help. So this is a long answer to your question. Yes, I give not only omega-3, but I also, because of the free radicals, I use N-acetylcysteine, NAC, which is also a very good, it increases glutathione, which, by the way, is deficient. I didn't go into the mitochondria. It's another huge area of research in schizophrenia. There is definite mitochondrial dysfunction in schizophrenia, so they don't make enough glutathione or superoxide dismutase, and that's why they become sitting ducks. When they have free radicals, they do not neutralize the free radicals. So that's why I add NAC also to the patient's regimen as a supplement, not approved by the FDA, but it makes sense to give it to them. And there are a lot of published small studies in academic circles that suggest that they really actually help. So that's my answer to your question. Yes, we can actually help mitigate the damage by adding anti-inflammatory NAC. And by the way, one of the most recent advances in psychiatric research is why not develop drugs that prevent microglial activation. We're targeting microglial activation as a way, as an intervention to protect the patient from psychosis. We don't have anything yet, but there's a lot of research going on to prevent microglial activation.
Very good, thank you. We have several more questions. I'm just going to read them in order here. So a question about treatment. So which of the antipsychotics has the least metabolic side effect outcomes, meaning things like weight gain, hyperglycemia, et cetera?
Okay, we have like 3 of them that I recommend. Out of the 11 second generation, the least weight gain is with Caplyta, which is actually lumateperone. It's the newest one on the market, came from Intracellular pharmaco whatever company. And Caplyta has not only 0 weight gain, it actually 6 months follow-up, FDA study follow-up, they lost 4 pounds. So it is actually weight loss. Then you have the lurasidone, the Tuda from Sanofi, actually barely 1 pound maybe after 6-7 months. And then Vraylar, which is cariprazine from AbbVie, also in New Jersey headquarters, I know. AbbVie makes cariprazine, which is approved for schizophrenia and bipolar disorder, and has minimal weight gain. Minimal, not only weight gain, sorry, the hyperglycemia and hyperlipidemia is also minimal with those 3 drugs: lumateperone, cariprazine, and lurasidone. The others, one of the older second-generation drugs is Geron, ziprasidone from Pfizer. It's now generic. Again, it was the most weight neutral. The worst weight gain, worst diabetogenic drug is olanzapine, Zyprexa, which is a very good antipsychotic, but unfortunately, it balloons the patients, and many of your endocrinologists probably see some of those patients because they develop diabetes as well. Clozapine is also very, very extensively bad for weight gain and glucose and lipids, but it's a life-saving drug that we use only for refractory patients. 30% of patients with schizophrenia absolutely do not respond to any antipsychotic. First or second generation, clozapine works in the majority of those patients, but with a lot of side effects like weight gain, diabetes, hypotension, seizure risk, myocarditis, pancreatitis, excessive salivation. But it's worth it because those patients actually become normal again after failing to respond to anything and have continuous delusions, hallucinations. So you pay a price of metabolic syndrome in patients that are that need clozapine, but then we give them the statins and the metformin and the antihypertensives to manage their metabolic side effects, because then it's worth it. Nothing else works. But when it comes to first episode patients, I never start with drugs that cause metabolic side effects, because first episode patients are extremely sensitive to metabolic side effects, and they gain weight very rapidly. It's very hard to take to shed that weight afterwards.
Thank you. Do you see similar positive results with use of LAIs in non-schizophrenic disorders? For example, mood disorders, bipolar disorders that have concurrent psychotic symptoms?
Absolutely. Bipolar disorder is a psychotic disorder. 80% of patients with bipolar disorder have a delusion, a hallucination, or both. And so, yes, we actually treat acute bipolar episodes with atypical antipsychotics. The majority of them are approved by the FDA for bipolar mania. And 3 of them are approved for bipolar depression, which is very important for you to know. Do not use Prozac and Zoloft and Paxil and Lexapro and all those drugs or Effexor for patients with bipolar disorder, many of whom have numerous depressive episodes because they destabilize the illness. They actually either don't work or they switch the patient to mania, hypomania, mixed states, and rapid cycle. So only in the last 15 years, Seroquel was the first drug approved for bipolar depression in 2006, Lurasidone in 2013, and now Cariprazine, Vraylar in 2019. So we now have 3 drugs that work in bipolar depression. They're all atypical antipsychotics. So it's a long answer to your question. Yes, we use the oral for those drugs. Now, what about long-acting? Absolutely. Risperidone Consta was approved for bipolar disorder as a long-acting injectable, but it's every 2 weeks, so it's a little hassle, too many injections. Abilify Mentana, a aripiprazole made by Otsuka, is approved for both schizophrenia and bipolar disorder. And Vega Sustena actually was approved by the FDA for schizoaffective disorder bipolar type. So I do use them long-acting for bipolar patients because they are notorious. The bipolar patients I have and everywhere, they are notorious for deliberately stopping their drug. They don't like schizophrenia patients. They have trouble remembering and motivation or anosognosia. They skip the drug because they miss the karma. They want to get their high back, the energy, the inspiration. It is so good to feel manic, but it's dangerous too. But they don't realize it. So I give them long-acting injectable as an insurance policy, along with a mood stabilizer like lithium or Depakote, in order to keep them up. So in case they stop their oral, at least they're protected with the long-acting atypical injectable. Okay, so remember, whether they have psychosis or not, long-acting injectables are actually anti-manic and can be used to protect those patients. Because, by the way, manic episodes and depressive episodes also destroy brain structure, and they get hypoplasia and atrophy in multiple brain regions. And I warn my patients, the more episodes you have, mania or depression, your brain is going to deteriorate, and you're not going to respond very well to medication. Very similar to schizophrenia, by the way. So it is really a serious issue as well with bipolar.
Excellent. Thank you. How important is stress in the prodrome conversion stage, and what is the role of the microbiome, given that it regulates microglial activation?
Very important issues, both of those issues. Yes, stress is a pathway to hippocampal degeneration. Okay, you have hypercortisolemia. Most of the glucocorticoid receptors are on the hippocampus, so you get destruction. If chronic stress, not 1 or 2 or 3 days, all of us have those. That's okay. But if you have like chronic problem with a job loss or a divorce or horrible things happen in your life, chronic stress, especially for people over 50, is very devastating. But for young people, you talk about schizophrenia, there are actually animal models, stressing animal models. You can get what is an animal model of schizophrenia, which it can be protected with an anti-stress medication. So yes, we believe not only that, but there's a lot of anecdotal evidence that just before the onset of the first psychotic episode, something bad happens in the life of those young people. They either leave home to go to college. So going to college is a huge stress from the protection of home. Now they're on their own, and they struggle with the studying alone in college, or they get jilted by a boyfriend, a girlfriend. Big loss there. That's very stressful for young people. So yes, stress does play a role in we believe in the and one of the triggers. It's not the only one, but the microbiome question is also very interesting. As you know, it's an exploding area of research, and there's a lot of papers now, a lot of studies in the microbiota, dysbiosis, and the diversity of the microbiota in the first episode schizophrenia has been shown repeatedly. And when you give them antipsychotics, you look at the diversity, and it actually, the dysbiosis is corrected. So yes, there is a link between the microbiome, which is the genome of the microbiota, and the brain, and it's involved in anxiety, in depression, and in psychosis, and even personality disorders, and on autism. That's why fecal transplantation is going on right now, to try and correct the microbiota in people who have one of those disorders. And one of the most exciting, I think it's exciting kind of developments in the microbiome is when babies are born with a C-section, it turns out instead of going through their mother's vagina in 20 minutes as they go through the vagina and get born, they get all the microbiome of the mom. This is how babies who have nothing in the utero, there's nothing, no microbiota whatsoever in the GI, they get their mother's microbiome basically with vaginal delivery. So what do you do? What happens to them when they're born C-section? They end up, according to studies that are published, they end up acquiring the germs in the hospital air, which is very bad. There's a lot of pathogens in hospital air. So what can you do about this? This is not good. Well, fortunately, suckling the mom's breast, you have microbiome on the skin. If the mom kisses her baby, the saliva has microbiome, it can pass it on. But one of the more innovative, recently published study is right after a baby is born with C-section, take some fluid from the vagina of the mother who just delivered her baby and smear it all over the skin of the newborn baby. And that will immediately give the baby what they would have would have acquired had they been born vaginally. Okay, so this is not something that is recommended for C-section because lack of a good microbiome at birth has been associated with developing, mental health issues in adulthood.
Very interesting. Couple more questions. So for some of our hospitalist colleagues here, so one of the challenges is, schizophrenia is initial diagnosis. So some of our hospitalists experience that psychiatrists don't want to commit to a diagnosis with their first inpatient consultation in the hospital. So even after medical illnesses have been kind of resolved or ruled out. So a lot of these patients are being discharged without a diagnosis or treatment. So can you comment as to how big an issue that is and how we may deal with that?
Absolutely. Yes, when patients come in with delusions and hallucinations, that's psychosis, okay? But many psychiatrists hesitate to call the patient schizophrenia because DSM actually has a category called schizophreniform. Schizophreniform is like a holding pattern for 3 to 6 months, and then you can switch it over to either schizophrenia or bipolar or pre-reactive psychosis or delusional disorder or something else, okay? I diagnosed schizophrenia on day one. As a schizophrenia researcher, I know how to diagnose it because it's not just positive symptoms. Okay, delusions, hallucinations, fine, that's psychosis. But I also look at the negative symptoms of the patient, flat facial expression, aprosody, anosognosia, and poor impoverishment of thought, impoverishment of speech. All of these are negative symptoms, avolition, apathy. And then I measure their cognition. I'm amazed that many psychiatrists do not do a cognitive battery for their patients with acute psychosis because that is a hallmark of schizophrenia. The presence of psychosis, negative symptoms, and cognitive deficits, especially memory and frontal lobe executive function, these are pathognomonic of schizophrenia. So I can diagnose it because I look at all those factors, not just delusions, hallucinations. They're right. Delusions, hallucinations by themselves, you cannot call that schizophrenia. You have to have the negative symptoms, the cognitive deficits. Okay, so this is why I diagnose the patient early and put them on medications approved by the FDA for schizophrenia in the first episode. I don't wait until technicality, change their diagnosis, whatever.
Excellent. Thank you. A couple more questions, then we'll wrap things up. So going back to the anti-inflammatory, someone asked, can you share what dose of anti-inflammatories or omega-3s are typically used in these kind of?
Yes. Basically, they have to buy it as a supplement over the counter because FDA, the insurance companies don't give it to them. So I tell them to buy the 1400 milligram caplets and take one twice a day. And there's enough EPA in there to really do the anti-inflammatory work. One caplet twice a day.
Excellent. So it sounds, another question, it sounds like your data and results are very compelling. And the question is kind of, what is the resistance? You mentioned that a lot of first-line psychiatrists are not pursuing this. They're using oral medications. What's the resistance to what seems to be an overwhelming amount of evidence?
It's a combination of things. In the 70s, when the first generation long-acting came out, with Prolixin was the first one in the mid-70s, nobody used it, even though data showed that it can protect patients from relapse. The reasons back then, first, they were ignorant. They didn't know that psychosis is neurotoxic, but there were other factors. Psychiatrists are a liberal bunch, okay? So they say, let the patient make their own decision. Okay, let the patient have control over their life and illness, which is baloney, because patients with schizophrenia have frontal lobe pathology, which is where we make decisions. This is the CEO of our life. This is where we make the wise decision in our life, planning ahead, learning from mistakes, avoiding hazards, and so on. Patients with schizophrenia cannot make that decision. You have to make it for them. A little paternalism serves the patient well until they get their insight back. So that was one reason, liberalism. Second, there was a lot of Freudian influence. Psychoanalysis was still powerful in the 70s. Fortunately, now it's much less. Because my own teachers in residency, many of them were analysts, and they would say, I don't want to penetrate the patient with a needle that is similar to raping them. They sexualize everything. It is a symbol of rape. I don't want to do that. Baloney. Of course it is baloney. This is where theories interfere with science. And then the most important thing is that they never even brought it up to the patient. They never told the patient, hey, you have an option. If you want, instead of taking pills every day, I can give you an injection once every month. Nobody even bothered to tell the patient about that. So they called it last resort. Literally, that was the name of the long-acting. The ignorant psychiatrists of the 70s and 80s and 90s, they said, this is a last resort. I'll use it only when the patient has been hospitalized 10, 15 times, enough already. That is totally reverse logic. You want to use it very early so they don't get the 10, 15 relapses and hospitalization. So it's a combination of things. And fortunately now, psychiatrists are getting it a little more than before, but still very few of them use it in first episode. That's my challenge, converting them to using it as early as possible, because the bang for the dollar is much better in the first episode. And good for our patients now, we have an injection every 3 months, an injection every 6 months. So and we were minimizing the needle, fear of needles, which I mitigate quickly by telling patients, look, I take vaccines, you do too, and it saves you from remembering every day to take your pills and getting to fight with your family about forgetting. And did you take it? Did you not? Sometimes you forget. And there's so many things to advantages to the long acting in addition to relapse prevention. Lifestyle.
Wonderful. All right. Well, we're right up around 9 o'clock. Dr. Nasrallah, that was wonderful. Thank you so much. Thanks to the audience for some great questions. And everyone have a great rest of the week, and we'll see you next week for Grand Rounds.
Thank you all very much. Stay well. Take care. Bye-bye.